First engagement grand rounds for this academic year. For everybody who doesn't know me, my name is Anique Forrester. I am the Chief of Engagement for the Department of Psychiatry. And so every year we have 3 themed grand rounds around engagement. And so we're very excited to have a very special speaker with us today. So last year, I was selected to participate in the UMB Costa Rica Faculty Development Institute. So in December of 24, I, along with colleagues from UMB and College Park in medicine, dentistry, law, social work, nursing, education, went to Costa Rica to learn about global health. And so Dr. Carlos Ferron Guzman was our main facilitator in the immersive learning experience around global health and systems in Costa Rica. And so I'm excited that he has agreed to come and speak to us all the way from Costa Rica. Dr. Ferron Guzman is an associate professor at the graduate school here at UMB and the director of the Masters in Science for Global Health at the graduate school. I'd also like to acknowledge Amy Ramirez, who's the executive director of Global Learning and International Services here at UMB, along with Virginia Rothorn, who's an associate professor in the School of Graduate Studies and the Assistant VP for Global Engagement at UMB. They were the 2 people that sort of coordinated our experience, and I hope they would be here today. I don't see them. Virginia. Where's Virginia? Hey, Virginia. So without further ado, I'd like to help me welcome Dr. Carlos Ferron Guzman.
Thank you, Anique. I somewhat, well, thanks first for the invitation, really. It's helped me with my, it's always great to be in Baltimore. I do not like to stand next to a podium, so I might be doing this. I just don't like to be hiding behind computers and stuff. So apologies for the people in on Zoom that hopefully I'll be able to stick to the mic. Where are the Zoom people? Where's the camera? Top corner over there. All right. No, I'm fine. A handhold would be better. Yeah, I think so. Thank you. This just allows me to move a little better when I'm nervous. I tend to move a little bit more. Anique, Dr. Forster gave me the challenge to come to speak to you all, and just speak to what you spoke about in Costa Rica. I think people will find it interesting, what's happening in the health system, some of the challenges, and this was one of the farthest. I usually find it pretty easy to flow and find things to talk about. Oh, I have to stay on camera though. This is why I'm here. The camera is on me. So I'll just stay here, don't worry. And so I thought about this for weeks and weeks. What should I come here and talk about? And what I'm going to share with you today is more of a reflection around health systems, more than what you would consider a lecture. Thanks. So just to get a sense who's in the room, which also is, it's a little loud. All right. A little loud. Is that better? I don't know. It's hard. Anyway, I can also, I know I need to speak to the mic because people are listening, right? Just to get a sense on who's in the room. This is a great start, by the way. How many here are health professionals? I just need to understand. A very broad term indeed. And how about clinicians? Most of you are. That's great. All right. So again, just want to take it back. This would be kind of really high level. I don't know if, can we do something about the volume? Because I do feel it's a little loud. Is it loud for you guys? Yes. Is it loud? I don't know if there's something I need to do over here. Appel? All right. Is that better? Is that better? Yeah, that is better. All right. So that's completely on me. I should have been here earlier to do sound check and stuff, but apologies for that. I should say, sometimes when I have conversations like the ones I'm going to have, it lands a little differently depending on the context, depending on where we are, and depending even when we are. Time also dictates how these conversations happen. And so I hope to be able to frame the conversation in ways that likely will sound familiar to you. Um, and perhaps it would be new to some of you in the room. Students, you're all health professionals, and all right, that makes my work, my job even harder. Um, let's see, I have to do here. Slide moving. All right, thanks. So um, this is a photo of Earth very, very far, and this is what I'm going to try to do today. Talk not from kind of a 40,000 level view perspective, but even farther from that, kind of go into the basics of health and health systems to see if it sparks some new ways of thinking about this um, of you. I should say that this is a context that I grew up working in, right? This is the southern Costa Rica where I have done most of my work, and when I was a practitioner, a clinician myself, and then a public health practitioner, this was the context that I was working on. Obviously, very rural, very hard to reach populations, very kind of what we consider last mile health, and working with community members. In that picture, you see me or a younger version of me um, with surrounded by women from the Nuevo Gle community, an indigenous community of southern Costa Rica, and we were talking about basically early pregnancy, teenage pregnancy, uh, and ways to come to healthier kind of outcomes if this was to happen in the community. It just happens to be that this community, this particular community of La Casona, had the highest rate of adolescent pregnancy in the country. It's a pretty small community of around 1,500 people, but still 1 out of 4 people or women in the community were having babies under before they reached the age of 19. So it was kind of a core challenge, working closely with them, the traditional birth attendants, the traditional healers. We try to create programs to prevent early pregnancy according to what they felt was an appropriate age to have their babies. So this is some of the context that is informing this conversation, and I'll bring some of what Costa Rica kind of has ingrained in me, in my understanding of what a health system is, and hopefully that will kind of shift some of the reflections that that we're going to have today. And then the other thing I should say is obviously as well, this is part of the context that I work at. Blurred some of the pictures where there's minors in the picture, but this is also kind of the context that we were embedded, or that we are embedded in southern Costa Rica. Some of the challenges relate to migratory challenges. Some of them relate to environmental challenges. That's a picture there in the top where you see a vast sea of monoculture. That's palm oil. There are challenges regarding emerging infectious diseases. There are challenges regarding interculturality delivered in health, maternal and child health. So all these things kind of what's informing this conversation today that I'm going to have. So I should say as well that the other thing that informs my thinking is this concept of nestedness, right? And complexity and systems thinking on how different systems are embedded within larger systems, right? And of course, these are images that are lung and trees and rivers outflowing into the ocean. This is how kind of we envision, and this is scholarly work I've done with indigenous peoples on how we think of ourselves embedded into these larger systems and the similitudes that might exist as we zoom in and out. So kind of want to do an analogy of that and zoom in and out today, talking first about the concept of health, then health systems, and then perhaps bringing it back to ourselves in more of a personal reflection of what it means. And then the other thing I should say that informs my thinking, and I'm sorry I'm spending a lot of time in this, is this idea of the different types of scholarship and where we land as scholars. I should say, this is when you think about, oh, I'm a scholar, I work in a university, I'm an academician, or whatever that might mean. Where am I in these circles of, I'm in the scholarship of teaching, of discovery, of integration, of application. Right? I mostly spend my thinking time in that lower right, the scholarship of integration. And I know a lot of you might be more of practitioners, applications, and some of you might be doing kind of the classical sense of research, the scholarship of discovery, right? I rarely spend time here, right? And this is why I'm, let's say, I consider myself less of a hard scientist, which is where I am right now. But I spend a lot of time there trying to talk through disciplines and walk through building bridges to try to create concepts that are useful in the application, right? So this is more or less just an overview. So let's start with I keep moving the wrong mouse here, with this simple question. And I assume so, right? A lot of you raised your hand as you said that you were health professionals. I'm wondering in the room, I thought this was going to be a smaller room. Virginia tricked me to saying, it's one of the small rooms. I'm like, okay, I feel comfortable with 20 people doing more of a facilitation style, perhaps with 50 people in the room, it's a little harder. But can anyone, off the top of their head, define or give me a definition that is commonly cited in health? Off the top of their head, just like, yeah, this is what, I'm a health professional, of course I know this, right? Because I think 95% of you are, yes. Yeah. Absence of disease is definitely part of the definition of health that is most widely cited when we talk about the definition of health. Anyone else? Has anyone kind of gone to like, what is this definition of health? Don't be shy. There's no, or what are components of it? I think there's a really good component of it, the absence of disease being one. Accommodation of function and ease is definitely part of how more modernly we understand health. Classical definitions. Yeah. So the WHO, or the World Health Organization, right, has a specific definition of health that kind of starts. I don't know. I know it by heart because I've read it 100 different times. So I'm just going to write it down here. It starts like a complete state of, and then goes through physical, mental, social well-being, right? And then it kind of adds a comma to say not merely the absence of disease, right? This is a definition that's been most widely used. Globally, it's still very much kind of a pillar of how we understand health. It has implications, I should say, has a strong implications. Definitions have really strong implications of how we understand things. This is WHO. And anyone know what year this definition came out? It's been here for a while. This is 1946 when it was drafted, adopted in 1948. So we're talking about post-World War II period where nations are coming together. They're really thinking about aspirational, what it means to build these ideas of these, conjointed nation states, how we understand these things. The United Nations actually kind of is or modeled after the idea that nations can come together to produce more well-being. So 1946, this is the post-World War period. Now, I should say definitions, right? Definitions as we understand them before we go into that definition have these kind of three different layers to them, right? One is the denotation, which is kind of the literal meaning of stuff, right? The literal meaning. We have the connotation, which is kind of the baggage, right? The values and kind of the meaning, the cultural meaning that words have. Uh, and then the operational is now what do we do about this word, or how is it, how do we operationalize the concept, right? So obviously, right, all of this comes with embedded values, right? When we talk about a word, whatever word, however innocent it might seem, there is dynamics that also shape the meaning and the operationalization of the word. There are values that shape the meaning and the as well operationalization of the world, the word. So I would say let's take a simple word that we kind of use daily that has been quite controversial lately in U.S. policy as it relates to healthcare, which is the word woman, right? Woman, right, has a simple definition on the dictionary, right, which is not always how we understand woman. In the dictionary, it says something like an human female. That is what it says in most dictionaries, right? However, when we say the word woman, it has, connotationally, it has, when we hear the word woman, we hear, gender roles. We hear, we hear the way it's interpreted for each and all of you is different. And then it has different operational consequences as well, how we define woman, whether it's, access to healthcare, economic opportunities, or policies that relate to the word woman, inclusion, exclusion. Right? So this one word, depending on how we define it, can really have these large consequences over policy. And this is kind of what I'm meaning when I say words carry values, words carry power, right? And I think in another life I would have liked to be a linguist anthropologist, as I'm always kind of exploring meaning of the words and how they can shape the reality that is surrounded. So as you're kind of starting to understand where I'm going, we see how we define health also carries a large amount of power, a large amount of value systems that are embedded. Because as we kind of know too well here in the United States, and although I don't live here, we know that words are highly political. When we hear the words freedom, liberty, all these carry these immense connotations of power and value. Right? And health as well. It's not a coincidence, right, that when we were talking about 1946 here, we're talking about post-World War, thinking about how do we harmonize, how do we bring people into a common understanding of what health is. But curiously enough, when you say the physical, social, mental, there's some things missing from here, or perhaps there isn't at the time. They weren't thinking about these things. Let's say, for example, the environmental in that definition, right? Today, we can't have a serious conversation about health unless we're talking about how environmental change is linked to health, right? We're talking about climate change and health, biodiversity and health. And those things are explored in depth in different fields like One Health and planetary health and eco health and others, which I won't get into today, but that's kind of another part I spend a lot of my scholarly time. So when we look at this definition, let's just start, taking it piece by piece so we can see where those some of those connotations and denotations and operationalization consequences have. So this was the definition, very post-war, very utopian, very visionary, aspirational. And let's start with this word complete. When you think of the word complete, right, perhaps give me some synonyms of what you are thinking of when you think complete. Whole, that's a good one. Intact, yes. Inclusive, that's interesting. Do you want to hear everything? Total? Incomplete, what's the first number that comes to mind? 100, right? So it seems that complete is this, we have kind of this shaped idea. And again, thinking about the connotation, denotation, and how we operationalize this idea of complete. And when it comes down to health, right, it kind of gives us this idea that health is, and I'm going to erase this for a second, that health is kind of binary, right? And it gives us this idea that whether, complete means whole, total, 100, kind of this idea of binary health, which we all know it's not real, but it still gives us that connotation, right? The idea of zero doesn't represent how we understand health today. Most people, right, today, I think 6 out of 10 people in the United States live with a chronic condition, which means that if that was the case, we're talking about immense amount of people that are not complete, right? Or perhaps I should just make it easier and just ask you and say, how many of you have ever felt complete mental, social, physical well-being, right? All at the same time, all 100%. It really adds this extra layer of almost impossibleness to achieve, right? And people say, no, that was the aspiration aspect of the definition. I can buy that, right? But then you have to operationalize that, right? Which then becomes a real challenge, right? It's almost like an impossible threshold. And it really focuses, right? When you say you are or you aren't, it also can easily lead to the over medicalization of things when you are not in the complete, right? And usually, what we do in the health system, then, because we agreed this is not something that is a binary, but we should say, health is a spectrum, right? These are kind of 5 functions, I would say, we do as health professionals and health systems broadly try to do, right? And if we think about health as this spectrum in different qualities of health, everything from the total absence of health to this utopian health, if we were to draw this as this chart, we are on a day-to-day basis moving back and forward, right? Right now, your health is different than it was in the morning, and it'll be tomorrow differently. You have different stress hormones in your body that are shifting. There are different cells in your body that are doing different things. There are different microscopic level DNA things that are happening, right? Which means actually when you try to do complete, it's impossible. There's always going to be, certain amount of in your body if we take, apoptosis as a normal physiological concept, right? I'm sorry if I mispronounced apoptosis. I've never said that word in English. I just realized. Um, so apologies for that. So talking about these 5 functions, right? We're talking about what are we doing in this spectrum, right? We're talking about promotion that we're trying to do in this spectrum. Basically, we're trying to increase the baseline, right? Baseline, moving people kind of into this healthier realm. But kind of pushing the baseline this way would be how I would describe promotion if we were to look at the spectrum. Prevention, right? It's about preventing people falling to this side of the spectrum. Cure, it's about kind of moving people acutely from this part of the spectrum, right? From ill to better health. Rehabilitation, it's more of a slow climb, right? Towards better health, right? And palliation, right, is trying to, with dignity, right, as health is declining, trying to make it, let's say, as dignified and comfortable for people. Some of you might be working on all 5 parts of this spectrum, or perhaps your work intersects more with one or another. However, right, what something is clear, right, is that despite the fact, and I'll show you some data later, that what has more bang for buck, let's say where we can make people healthier, is in the first 2. Promotion and prevention is where there's kind of the most best cost efficiency, so to speak. We spend most of our time, most of our resources, most of our, precious education focusing on aspects of cure, rehabilitation, right? This is where most of time is spent. And when we look at resource data, and I think I have a slide here of that, right? When we look at health data, this is a data set from the OECD, which more or less is the rich country club, as people say, right? Costa Rica recently became part of this OECD organization, the Organization for Economic Cooperation and Development, right? In which they track different stats around the world. I'm losing my first couple of people here. This is spending on primary healthcare services as a share of current health expenditure. That is the money that is being spent on healthcare. How much of that is being spent on a primary healthcare? The US doesn't even make it in the chart, but it would sit in the lower right below Switzerland. It's more or less 5% of the US expenditure in healthcare focuses on primary healthcare, which is very little, even when you compare it to kind of the lowest of the low, right? And you can see that Costa Rica has relatively high expenditure. If you read kind of the list to the left, you have kind of the countries with strong social systems like United Kingdom, Finland, social security systems, I would say, and as you go to the right as well, kind of gets more of the private healthcare systems or the mixed healthcare systems, right? So this tells you part of the story. When you think about this, although we know that more bang for buck happens in cure in promotion and prevention, we still oddly spend less time and less money, less resources uh, in the things that matter the most for most of the people's health. And this is a reflection as well in our curriculum. I assume most of you are studying in the health professions. I studied medicine in Costa Rica, and I can tell you the representation of promotion and prevention is very, very little. There's some stats out there, something like most medical students today get something like 20 hours in average of nutrition education, which obviously being food, one of the most important determinants of our health, that's very little. I just gave you some statistics on how much we spend. There's very little representation of determinants of health in our curriculum today, right? There's very little even career advancement in these two things. And when we think about what we aspire to do to become renowned and recognized and even financially stable, right? As health professionals, we are usually looking at the bottom three parts of this. And of course, as clinicians, you understand that much better than I do, that I work in public health, right? So this is part of kind of there's a incongruency or there's kind of a dissonance between what makes sense and where we spend our time and effort, right? So let me move forward. Then we have this idea of the word, the complete state, complete state, complete state. Now, people say, health, is it a state? Well, first, when you hear the word state, it's kind of a snapshot of something, it's a state is like a moment in time, right? And perhaps I wouldn't say state is a bad word, but if you were to define health, when you talk about a definition, usually you have to start with a noun, right? So health is a state, right? But if I was to ask you, what other words could potentially be there? Does any ideas of any like, oh, health is not just a state, health is an experience? It's a good one. Huh? A condition's another good one. A balance. A process. People say health is an asset, right? Health is a vehicle towards achieving what one wants in life. So people have started changing this idea that health is a state to more something that is more of a process, more of a dynamic, more of a way to, make the most of life of what we want it to be, right? And that second part, right, what we want it to be, some people come from more, let's say, a, a perspective that it should be for achieving goals that are valued in giving society. So very contextualized. And so state is not necessarily a bad word, but perhaps there could be some descriptors of state, right? And perhaps we should put dynamic state. Health is a dynamic state, and that way we can understand that it's not static. Well, it sounds like static, right? State sounds like static, but perhaps if you add some descriptors, we can move forward and kind of start thinking about health in another way. Even there's scholars that work here, they say health is an ability, health is the ability to self-manage, et cetera, but that's not the main point. So now let's get to the kind of the other core parts of the definition, which are the physical, the mental, and the social. Now, obviously, these are hard to separate, and as you read these, right, you're saying these are words. They're probably really hard to separate and define. But when we're talking about the physical, so just we're on the same page, what is it that we're talking about? Is this physical health that we're talking about? How would you define physical? Okay. One way? It's hard. No, I'm asking you like super obvious questions, but they're not obvious when you kind of are reflecting upon them. Right? Physical, like kind of the word itself refers to the physical, the physics, what can be seen, touched, measured quantitatively, more or less, right? It's kind of those things that can be observed in one way or another. It's a hormone, a cell, a piece of DNA, your hair, your liver, your body, right? Something that you can see or measure directly or indirectly. More or less, that's what we're talking about when we talk about physical. But if I was to ask you, how do we measure physical health? Like when you're out there in the clinic saying, let's measure the health of this person, what do I usually do? Blood pressure is one, right? Blood pressure is kind of measuring the pressure of the vessels inside your body, specifically the cubital. Oh my goodness, my anatomy is failing me now. Right? And we do that through vitals. How else do we do it? Imaging, right? We might take a scan of the brain, see how the brain is physically doing, right? We might do things like biomarkers or the amount of cells in a cubic centimeter of your blood or millimeter, whatever it might be the measure, right? We might measure a specific hormone in your body or the amount of neurotransmitters in a specific amount of time, right? We're saying, okay, that is the physical world. Right? That is what I can measure very quantitatively and say that is the physical, right? I think most of us can understand that much more intuitively, right? But about the mental, I know most of you are probably here working in mental health. How do you define the mental aspect of health? What are some words that are associated with mental usually? Usually emotions, cognitive, resilience, the ability to act like that. That's kind of nice. But then kind of nice, right? Um, then we have like things that when obviously the mind and the brain are not the same thing, and you know this quite well. But all these emotions and cognitive and resilience and love and feelings, all of this emerges from the brain, which is a physical structure. Why do we separate physical and mental? Why are these separated as different domains of health? Why do we have mental health clinics and then just clinics, right? Why is that separation done? Where does the separation come from? Insurance is one reason, for sure. Systems, right? As I was saying, there's another to value the fact that systems can create meaning, right? Just like meanings can shape systems. That relationship is definitely. But this tension between the mind and the brain, right, is not new. This is something that kind of predates us and predates modern times, but it has been interpreted in different ways in our modern system, right? So, but sometimes, right, we say that feelings are not a physical thing, or that should be something of the psychologist that sees the mind, whereas neurologists see the brain as if they were separate. I think psychiatry sits somewhere in the middle, which is an odd middle to sit in. But it's important to note, right, that again, the connotation, the denotation, and the operationalization of these things are important, right? Perhaps in the future, there will be a perfect machine that can scan my brain and can tell me everything about how I'm feeling, what I'm thinking. And then that separation between the physical and the mental will be even more reduced. But for I think most of our processes that relate to the cognitive, to the emotional, to the psychological are still barely understood, I would say, how our brain functions. And so we separate them. But then there's also the political part of separating them, right? It's making it a thing that we need to care about. Right? It's making it a specific thing that we can use as a tool. And people know exactly what you mean. What's the connotation of saying mental health is important, just as we say the health of the planet is important, what we call planetary health today. It's a political tool that we use as well, right? And they wanted to point to that. The originators of the 1946 definitions, when you look at their logs, when they look at what the things that they were discussing the importance of making sure that everyone knows But health is not just your body. Health is also your mind, right? They were trying to make that super clear, and that's why they added mental. It was a political move, kind of, that had this power to do that. How do you measure mental health? Usually, you're all experts in here. What is it? DHQ9? I don't know. Is that correct? Can I remember that correctly? Mini mental, right? Is another way we measure. What other ways of measuring mental? There's functional assessments as well. There's many ways, right? We can go out and try to measure that. At the end, I do believe those are all physical processes, but separate them as a purpose. Right? How about the social? Describe the social. How do we define social? It's getting harder, right? Connection, interaction, and those are very good words, right? When we think about the social, we need to think about something that emerges from connection, from interaction, right? It's something that is non-tangible, differently than the physical and the mental, right? It's what emerges, something new that happens when two people or more connect, whether it's the rules of how we engage, things that we call culture, right? Or sometimes we call that policy, or sometimes we call that governance, or sometimes we call that economic trading, right? All these things that emerge from interaction is what we call the social. What realms are usually embedded in the social? When we talk about social health, what are we usually referring to? Insurance, definitely, right? As part of how we access differences between people and how those differences then are, let's say, operationalized in one way, whether it's through exclusion or inclusion or racism or patriarchy, right? All these terms emerge from social relationships, and we know that we have consequences on health. How is this usually measured? How do we usually measure social health? The relationships, where we don't go measure how many Facebook friends you have, right? You don't, right? Well, that's not what we do, right? We could. Okay, there are measures of social networks, right? And we do social networks, but not necessarily through silly example of Facebook friends, right? We do that otherwise, right? We can measure social networks. What other ways do we measure social health? Or the, I'm sorry? Unmet social needs, so what are those? House, food, education, the banking system, right? All these things that we kind of, that support people to be able to function in society normal, including social networks, right? Loneliness being one of the main predictors of health outcomes or negative health outcomes, right? The kind of the death rate that multiplies when someone is suffering from loneliness, the adverse health outcomes that come from that. So we mentioned that sometimes in the lack of social networks and sometimes in the form of social. So these are all things to think about, right? We know, again, I'm separating them for the sake of understanding them, but we can see how, as I was just saying from the example, social isolation as an example of social health or lack of social health has deep implications over mental and physical, in the same way these things are interconnected. And again, these are just words that we use to separate and make a point, right? And lastly, right, but not merely the absence of disease and infirmity as a definition goes, right? It goes, health is a complete state of physical, mental, social well-being, and not merely the absence of disease and infirmity. Now, when was this put there? 1946. And again, this was, reading the people that were studying these definitions and critiquing this definition, they all agree this might not seem revolutionary today, but a heck of a lot of revolution was happening by adding this. Right? It was mostly pointing to the fact that the health systems, right, countries around the world, talk of health as the mere absence of disease. And when you have that definition, when you operationalize it and you say, okay, here's this Ministry of Health, here's this Department of Health, here's this, social security system that's looking out for the health of people, you operationalize that into policy, into laws, into actions, into resources, it ends up looking like the health system is just hospitals curing people, right? That's the implication that health, as the absence of disease, has, right? Definitions shape realities and shape our world. by putting this, they're making that point clearly to all the nations that were trying to follow this definition of health and saying we have to build health systems that support physical, mental, social, and later environmental, not just this idea of the mere absence of disease. So this is extremely important to put in there. And actually, one of the main proponents of this is one of the, as I was reading recently, one of the founding fathers of one of the first public health programs here in the United States, in the, if I'm not mistaken, University of Pittsburgh. So this is kind of how we think of health, right? That was our first question. Now, the second question is, does health depend on, right? And again, we've been talking about this directly earlier in this week. When we think about this question, our mind immediately goes to one of these two graphs. This one, right? Where I think everyone's seen this graph, kind of a classic graph when we talk about, what does health depend on? This is not necessarily about health. This is more about premature death. But this graph is used commonly to say most of people's health does not depend on what happens in the hospitals, right? This is something that we've summed up before. Then the other thing that comes to people's mind is this other graph, right? The determinants of health graph. Now there's a debate here. Should we talk about determinants of health? Should we talk about determinations of health, right? This is emerging from critical literature in Latin America. But basically, these two graphs basically answer the question, what does health depend on? Whether it's our individual lifestyle factors, which is what the determinants of health ask, determinations of health would ask, what leads people? What are the processes that lead people to make those individual choice factors, right? It might say determinants of health, oh, smoking is an individual choice, right? The determinations say what processes lead people to smoke, right? It's a different take, right? This might say, okay, what is poverty is a determinant of health. That's the determinant of health perspective. Determinations say what are the processes that lead towards poverty, right? So it's a different way of thinking. Well, however you want to see it, right? This is basically they're asking here, this is the rainbow model, myself in the middle, whatever is closer to me, we call proximal determinants of health, whatever is distant, we call those distal determinants of health. This graph here, more newer from the WHO 2008 Commission on Determinants of Health, right, basically flips this around and starts talking about more structural determinants of health. And that's why they call policy, governance, macroeconomic, social, labor market, basically very pointing out that policy plays an important role on how we shape and how determinants of health are shaped. So this is kind of the way of thinking on how we understand the question, what does health depend on? This is another way of thinking of health, which I've written some things about, right, in which we understand health and what is happening here in this part of the graph. This is basically a milieu, right, a milieu of determinants of health, flying around, all surrounding, everything from gender to food production to education to access to justice to health systems. They all kind of constantly interacting with each other until you reach health, right, or the lack of health, as you can see from this part of the graph, right, in which kind of health can kind of toggle up and down. And we understand health as a dynamic product of this eco-social system, and this is what I'm calling an ecosystem. When you see this graph, you can clearly see the interactions, right? Of course, things like socioeconomic status interact with education, and education at the same time interact with socioeconomic status, and interact with ethnicity, with social capital, with gender, etc. So there is a mix of ways we can understand how this, and it's not the point that you understand that all these interactions, it's the point that you just understand that these are interacting sometimes in complex ways, sometimes in ways we know, in ways we can measure, sometimes in ways we can't, right? But importantly, these things will vary from time to time, from place to place, and from person to person. So three determinants are added to these layers, which is who I am, where I am, and when I am, right? Think about classically your role and which of these, or who you are, I mean, which of these have a bigger weight on your health, right? And think about when you change context. Think about that when there was a administration change in the United States. What happened to your health when that administration changed, right? So when and where, and what happens to you when you move to somewhere else, wherever that might be, your weights or the weights that these determinants play really are different. And part of what I want to bring back to is that no matter what determinant you're talking about, Again, the determination of health framework, not the determinants of health framework, the determination of health framework. When you pull back the curtain on each of these, whether it's socioeconomic status, ethnicity, gender, inequality, at the end, these are all value choices, right? These are choices that are made by people in power that are sometimes elected, sometimes not, right? But they reflect a set of values, right? How the system is shaped is just a reflection of a set of values. And this changes from place to place, from person to person, from time to time, right? So, but it's important to talk about values because we rarely talk about values when we're talking about policies, right? We just, oh, we're going to vote for this policy, we design this policy, we think of this policy, we do not necessarily have a value-based policy system that really is transparent about that. Okay, and the way you operationalize some of this, you might have heard some concepts like health in all policy, in which we think about things like food policy is health policy. Yes, transportation policy is health policy. Agricultural policy is health policy. Education policy is health policy. So this framework of health in all policy that's been popularized by Canadian scholars really lead us to understand that all these things are connected to health, right? So when we think about then what a health system is, if we go back to our classic definition of how we understand health or how we learn about health, it really leads us to think that the health system is this reductionist thing that where we cure and rehabilitate, sometimes we prevent, right? But as I'm talking about health systems, we see what I want you to visualize is that expansion of the understanding of what a health system is. At the end, a system, in the most simple definition, is just component parts working together towards a common goal. That's the simplest definition of a system I can think about. And I'm going to say it again. Component parts working together towards a common goal. In this case, the common goal of the health system is health, right? So when you think about, if we think health policy is educational policy, health policy is agricultural policy, health policy is transportation policy, then we expand our idea of health system, right? But still, the WHO has these frameworks that kind of reduce health systems to what we traditionally call health systems, which is where we all work in traditionally, right? The service delivery, the health workforce, the information flows, or data that emerges, the medical products, the financing, the leadership, right? Or the policy or the governance, whatever you want to call it. This is classical understanding of what a health system is. I'm inviting everyone to understand that health systems are much more than that, right? Costa Rica, I think, as an example of that, in the sense that our Constitution of 1949 really tried to create a broad understanding of what bienestar is or well-being is, involving different organizations like water, like electricity, like housing, like education, all part of this well-being system that works towards not just health, but happiness, well-being. And curiously enough, happiness is also written in your Constitution. Right, so I'm rushing here because I'm running out of time and I want to make sure that we have enough time. I'm almost done. There's another understanding of a health system, and I think this comes from, I don't think this comes from the Partners in Health framework, in which they clearly are pointing to someone here. They say, yes, space, stuff, staff, systems, all very important, but they say this part is the most important, social support. So when we think about clinicians, mental health professionals, how much do we involve the networks, these safety networks, these social support networks that our patients come in here to today? I'm sure psychiatry does it much more than anyone else, but when I speak to different professions, they're really involving the social support networks in order to carry on with appropriate treatment. So this is getting to something how we rethink what a health system is. And again, shaping it back to values, what you put in front, whether the cooking ingredients of your system will undoubtedly shape what your system looks like. This is what's written in the organic or constitutional laws of our social security system in Costa Rica. And I should say, Costa Rica is by far not a perfect place. We have extremely amount of challenges, but we've gotten some things right. And when we design a system that in its inception, in its law, in its organic kind of composition, you have things like universality, solidarity, and equity, then that shapes the system to behave very differently than other systems. So what would you say are the values that shape the US health system? at the core. Well, it's hard to talk about the U.S. health system. I always say the U.S. healthcare system is not one system; it's many systems. What do you think is at the core of the value system that drives profit, capitalism? Unfortunately, these might sound like funny, but at the end, people are making decisions based on bottom line, right? Not on the increasing amount of well-being that people can achieve, but on bottom line, especially when it comes down to private sector, which is not the case for all parts of the system. I don't see the VA or other parts of the system behaving in this way. They have a different value system. But a lot of the United States healthcare system, especially the privatized one, does value those things. So when you design systems, think about the values that are embedded in the design process of that system, and it will come out differently. I'm going to finish with reflection here around kind of how that plays out at a very local level. How does that play out? How are these expanding understanding of what a health system is, what a health professional is, what a value system that pushes different understandings of healthcare systems are? Coming back to where I used to work, and I got to point that the top left here, that's the place where I used to work every day. And you say it says EBAIS La Casona. EBAIS is a community health clinic. It stands for Equipo Básico de Atención Integral en Salud. So we're basically a team of different health professionals, including community health workers, including nurses, including medical clerks, including pharmaceutical technicians. We come into community every day. We deliver healthcare services. We go out to the community as well every now and then. But that used to be the infrastructure where that healthcare service would happen. This is the indigenous territory of La Casona, and it would not be uncommon to see only women attend. Obviously, there were some gender components into who goes to the clinic and who doesn't. Now, to the bottom right, you have two people that are leaders in different parts of the community. Dr. Pablo Ortiz, who unfortunately passed last year, he used to be my mentor, and he directed the healthcare system of the region. And to his left, right, Alejandro Solomon is a traditional healer in the community as one of the community elders. And they worked together in order to redefine what the healthcare system is in this specific part of the community, right? So we wanted to one of the things that Dr. Paulo Ortiz did very well was fundraise. He was a great fundraiser. And he went to the Spanish embassy and guilt tripped basically into funding a new clinic for this community. Obviously, you know what the guilt trip might be related to, right? And he got to redesign what a clinic could potentially look like. So we went from there, right, to a completely different vision of what a clinic looked like. Thanks to community-based design, thanks to very trustful relationships that they were established. And as you can see here, there's some coincidences, right, in the design process of how the Nove Bugle traditionally lived, right, in these extended family nucleus, right, where most of health happens for them in their cosmovision. Most of the health happens in this interaction between them and the land, but also them and their immediate social network. We try to recreate that in the design process of this clinic. And one of the things that was embedded in the design clinic is that there would be intercultural clinic. There would be actual health professionals from the community, be it herbalists, be it traditional birth attendants, be it medicine healers, that would take part of the actual healthcare delivery. La Caja, years later, said, "Oh, I don't know about this. You know, it doesn't sound right to call these people health professionals." So there needed to be some reshifting on the. This is a concrete example on how we can actually, you know, apply these concepts, even if it sounds like this is in the middle of nowhere rural. This is the experience I wanted to share with you. So next time you think about these questions, right, whether it's, you know, what is health, what does health depend on, or what is a health system, hopefully this conversation or this reflection has expanded that a little bit. It has made you reshift what that professional identity means for you. And hopefully next time someone's asking you, what does health mean? You can point to 1946 and 1948 and say, I know what it means. Okay? All right, thank you for that. Thank you for the attention. And I know we still have I know we still have some time. I'm sorry for the people on Zoom. I know I was off camera like most of the time, so I apologize. I'm real.
Thank Dr. Ferron Guzman for a wonderful talk. I hope that this conversation was enlightening and sort of helped to shift some perspectives and to think outside of the U.S. context when we're thinking about health. And so I hope you all sort of got something from that. And so with that, if there are questions, we have a mic. I'm happy to run around and gather questions.
Or just observations are as well. Doesn't need to be a question.
Thank you so much. And also from the legal corner, the law school corner over here, I wanted to point out that also in 1946 was the Universal Declaration of Human Rights that supported countries or obligated countries to provide the highest attainable standard of health. And that was, I believe, incorporated into the Costa Rican Constitution, but not the US Constitution. So we've always been behind the community of nations in terms of having the right to health in our Constitution. And everything flows from that, I think. So just thank you for this.
Thank you for that wonderful talk. It's rather mind-blowing to think about some of our own experiences in the context that you put in front of us. What popped into my head is for a good 5-6 years, we've been trying to construct a robust women's mental health, particularly perinatal health program. And when we canvassed the community on the west side of Martin Luther King, which was historically redlined in Baltimore, the request from the community was, we want our care in our community. We want space, that we want services right in the neighborhoods that we live in, which puts that request in a whole different light for me personally. We also had a request to grow midwifery to a much greater degree. People don't want to come even 5 blocks across Martin Luther King into a tertiary care hospital to deliver their babies. And again, puts it in a very different light from this context that we're thinking, oh, well, how can we deliver the best care to the most people would be to have one place where everybody comes. And yet what you put forth today is so much more meaningful. So I thank you for that.
Appreciate it.
Yeah, I really loved your talk very much. And I am a psychologist, and most of my clinical work actually has been in home-based care, which, is not a very widely adopted, so doing actual therapy in people's homes. And so I just like to point out, it's easy to sort of look at our national values and legal systems and things like that, but there is professional complicity in some of the problems with our health system in the United States. People who are willing to sort of work in less than glamorous clinics that you were just, implying, Jill, or sit on families' floors and do their work. I mean, it's we gravitate towards settings that are comfortable for us as professionals. We like to wear nice clothes, we like to have air conditioning and those kinds of things. And I don't know, like as we move towards a more holistic view of this, I think we have to examine our own values.
Absolutely.
Hi, I'm Danielle Jones. I'm one of the consult psychiatrists who works with HIV patients here at the University of Maryland. Also have a master's in public health. Thinking about this talk, it makes me think about the trip I took to the United Nations in New York City, specifically thinking about how their focus now is on environmental health and specifically about pollution and other things and how that impacts other communities across the world and how our plastics can end up in other lower income areas, which affects help for other people and how we're living in a global community, that we're not always being good stewards to our neighbors or to ourselves, and how essentially the United States, for example, is not putting in our fair share towards the United Nations. So when you're talking about systems and health, I think about not only what are we doing environmentally, individually, but as a nation, and even in certain communities, even within the United States, how we're poisoning ourselves. So it's like the income inequality on multiple levels between nations, states, So you gave me a lot to think about, and I realized I just kind of threw a lot out there, but I really appreciate it. And hopefully a lot of our residents and other people think about what are some of the things we're doing individually day to day to be good neighbors and good members in the community, and maybe what we can do in the future to advocate not only for ourselves and our immediate neighbors and patients, but even for the state at large.
Appreciate the comment.
Okay. One final comment, if there's nothing else from the audience, from Dr. Rockweisel.
I just want to add a question up there that I think all of us would come up with different answers. The catchy thing now is value-based care in the United States. And, what does that mean? And again, this talk sheds a whole different light on that. It's from a capitalist view. Value-based care is less expensive care. It really focuses on the finances rather than true values of what determines health care. So that
Thanks,
should
sir.
be another question.
I'll add it for my next time. Thanks. Thanks everyone for your attention. Hopefully lunch was good because I'm going to have one. Thanks again.
Went well.
Yeah, I think it did. Thanks.